Good morning, everyone. Welcome to the June 23rd Learning Collaborative. It is great to see all of you. I'm going to go ahead and share slides so we can do our check-in. If you've been here before, I'm going to ask you to put your name and your organization into the chat. And if you're part of a large organization, please also put your facility just so we can see who's joining us here today. Are you able to see my slides? Come on now. Okay, awesome. Yes, so good morning, everyone. Great to see you. If you could please put your name, your organization into the chat, and if you're from a large system, please put your facility too. And our community check-in this morning is the question, what is something that you might value more than the next person or most people? So what's something that really brings you joy compared to another thing that you might value a little bit more? I don't want to pit people against each other, but I really love a movie theater. Like, I just love the movie experience, and going to a movie is way different than like watching it on my couch for me. So that's like my example, if that helps. Ooh, Courtney, people watching in the airport. That is a good one. I love to people watch at the airport. Good morning, everyone. Happy Thursday. Thank you so much for hopping on. Right at 10, if you're just joining us, please put your name and your organization into the chat for attendance and your response to our icebreaker today. What's something you might value more than the next person or most people? I saw, Carly, you also said talking to strangers. That's a great one. I don't think everyone on the call would agree with you, but I love to chat. I've loved that about Colorado so far. I feel like most people are pretty chatty. Today, as we're getting started here, I just wanted to let you know that the office hours are going to be immediately after this Zoom, after the Learning Collaborative. So I'll just be hanging out in this same Zoom room if you want to hang around, ask any questions, share any updates, anything like that. Before I turn it over to our guest speakers for the day, I'm going to give you a brief roundup of Colorado Zero Suicide updates and resources, hand it over to our wonderful speakers for the day. And as always, please use the chat for any comments, questions, etc. as we go along. But again, if you're just joining us, please do drop your name and your organization into the chat, because that's how we keep track of who's with us today. Just for the sake of time, I'm going to run through some of these updates. So out the gate, I want to let you know that the next Learning Collaborative will not be on a Thursday at 10 a.m. As is usual. It will be the Wednesday right before, so Wednesday, July 27th at 10 a.m. Again, the Learning Collaboratives are all recorded and the slides will be posted. So you'll also be getting that information via email. And that is actually to accommodate 2 workshops that we are piloting for those implementing zero suicide and otherwise in the state. That's a brief cognitive behavioral therapy workshop from the 28th to the 29th, a 2-day virtual workshop. Registration for that one is filling up quick, so if you're interested, please check out the link that you were sent via email. Also a crisis response planning workshop, which is embedded in the brief CBT workshop, but we're offering standalone as well on the 29th. So please do register if you think those would be useful opportunities for you. And then also, I wanted to wish everyone a happy Pride Month. June is Pride Month, and this is often an opportunity to celebrate the LGBTQI plus community and be connected to resources and learning opportunities. So I listed a couple zero suicide relevant resources here. Free webinars, on-demand things you can just go to on your own time to help your providers and your practice really provide affirming, warm, welcoming care to LGBTQIA plus individuals. So please do click through those links following the Learning Collaborative. And then the last 2 opportunities I wanted to plug really quickly is a mobile crisis funding opportunity through SAMHSA. That's due July 25th. I know they've been having semi-regular webinars for that application process, but again, great opportunity if that's something that you or your community would be interested in. And then also the lovely folks over at Centura and Resilient Colorado are hosting a trauma-informed suicide prevention session in Spanish and English on July 13th from 1:30 to 4. And again, all those links are live in the slides, so please do check that out. If you would be interested there, glad to have more folks there. All right. Again, if you're just joining us, please do put your name and your organization into the chat for attendance. But I'm going to go toss the baton over to our presenters for the day. That would be Meghna Pata, who works at CDPHE with me. Very lucky to call Meghna a coworker and excited for a presentation today. And then after Meghna presents, we'll hear from the regional health connectors about the amazing work they have going on. So I'll stop sharing my screen, and Meghna, feel free to take it away.
Thank you, Conlon. Okay, I'm going to share my screen. Hopefully this all works for me. Okay. Hopefully you all can see that, and please let me know if it is showing up a little off. Okay, perfect. Seems like it's all working. Okay, so I will just go ahead and get started. Hi, everyone. I'm so excited to be here today. My name is Meghna. I use she, her pronouns. And like Conlon said, I am the community outreach specialist here at the Violence and Injury Prevention and Mental Health Promotion branch at CDPHE. I'm so excited to speak to you all today about some past initiatives that I was involved in to build rapport with refugee and immigrant populations. As with any presentation I usually conduct with suicide prevention, I personally like to start with what brings me to this work. And specifically for me, my mom is a suicide attempt survivor and is an immigrant woman herself. And at the time, I was the eldest child and her only family in the States. And so I really tried to help my mom navigate the healthcare system and find resources for her that were culturally appropriate, translate for her, all sorts of things. And in general, we both had a very hard time in the medical system. And I've spent years since then trying to do the same work to build in more resources for immigrants and refugees. And so I know I've said this before, but I'm really excited to be here. So with all of that being said, I will just get started. Okay, so I wanted to make this presentation a little bit more interactive, and I wanted to pop some questions for you all. So feel free to put them in the chat. My first one is, are you familiar with the role of cultural brokers in healthcare? If so, has anyone incorporated cultural brokers as a part of their care team? And I will pull up the chat to see what everyone's saying. Okay. Oh, I see a few yes. Okay, and no worries if not. I will, as a hint, go over it later in my presentation. Okay. So feel free to keep putting your answers in the chat. I really appreciate the participation today. So my next question is, oh, there we go. So do you incorporate screenings for psychological triggers, specifically when providing services for refugees and immigrants? This could also be in the form of general trauma screenings. Oh, okay. So I see a few mixes of yeses and nos. Okay. So as another hint, I do go over this as well later in the presentation to hopefully maybe give some ideas and just what's worked for us and what hasn't worked for us as well. So, ooh, okay. I love this. Thank you. I really appreciate the participation, and hopefully this presentation is useful and also exciting. So I will just move on, but please feel free to put your comments and everything in the chat too. Okay, let's see. Oh, there we go. Okay, so I will just do a brief overview. Thank you all for participating in the last two slides, like I said. So a brief overview of what's ahead is that I will be discussing broad community engagement best practices. Also building rapport with immigrant and refugee populations as the big portion of the presentation. I'll just be incorporating some experiences I had in New York, cultural brokers versus translators, and like some community outreach stuff that we did to local organizations. And then I'll end with a Q&A. Okay, so we'll start with the broad overview. Okay, so let's start with a basic definition of community engagement, which is a two-way exchange of information, ideas, and resources that offers opportunities for the communities to exercise power in decision-making. And community engagement can and should incorporate community member compensation. And so just building that into budgets and just really thinking about that ahead of time, or even during the community engagement process. This can also include ensuring organizations budget for language services like translation, are resources available in different languages, holding Zoom or virtual meetings with translation features enabled whenever possible. And so all of this with community engagement is really a tool for providing culturally responsive care, which includes recognizing and honoring the diverse ways of communicating. It strives to create an environment where all people can be understood and can understand. Okay. So I also wanted to have like just a brief equity statement. I really like to also incorporate these in my presentations. BIPOC and LGBTQ+ communities have unfortunately historically been harmed by the medical community and the medical establishment with racism, discrimination, homophobia, transphobia that has been perpetrated by the medical community and society as a whole. And so the Office of Health Equity at CDPHE offers a glossary of terms, and it's embedded in the presentation for you all to look at after. And that can be just shared vocabulary that you all use, and maybe you already use some of these terms as well, which is great. And so just like maybe some shared vocabulary that can be incorporated as like a little take home, I guess. And so also to kind of like remediate some of the harm that has been done, there are different strategies like power sharing and power building, which are integral in creating more equitable strategies in suicide prevention as a whole. So some power sharing examples include selecting community members to be a part of councils, boards, and more with other community members, having community members co-facilitate meetings with you, co-creating the agenda and finalizing it to really emphasize the importance of their perspective and their participation in all of the work that you all do. And so some power building examples include internal decision-making, prioritizing lived experience and equity goals, and ensuring that people of all abilities and identities have access to programs, resources, and supports. Okay, so there is also a community engagement toolkit that the Prevention Services Division came out with this year. This is again another like take-home thing that I figured I would embed in the presentation for you all to look at, and also goes into power sharing and power building in a little bit more detail. This toolkit also includes self-assessments for programs on integrating community engagement into programming. So programs that haven't really been doing a lot of community engagement and just giving some more ideas of where to start. And then also for an assessment for if programs are effectively integrating community engagement practices into the current work that they're doing. And these assessments I thought were really interesting and really helpful. And so feel free to take a look at that after the presentation if you find it helpful. Okay, so now we'll go into some of the past initiatives that I've been involved in, specifically at Bellevue Hospital in New York. Okay, so Bellevue Hospital has a primary care safety net clinic that provides services for unhoused people. And so there we led an initiative to help providers and the care team build rapport with patients utilizing the clinic. And what we did is that we interviewed patients and clients so that we could better understand what needs were most pressing for them, and really shifting the conversation back to them as opposed to just assuming what we thought was best for them. And so that was our way of like power building and power sharing. Because I think sometimes the medical establishment can be a little patronizing in times with just knowing what's best for patients and clients, when we should really be asking and incorporating more of a shared decision-making model. And so we incorporated these, we distilled it down to 3 most important, most pressing needs that we came up with in conversation with patients. And we put these into the goals section of EPIC, the electronic medical record that Bellevue uses. And so then we were able to kind of track progress of these different and important things. So for example, I included like finding housing that let partners stay together, help with citizenship. And so we were able to track the progress of that, and also let at every visit, let patients know that, okay, we obviously are making progress on this. Like, is there anything else you want to add? And just really shifting that conversation, like I said, back to them, and that just letting them know they feel heard at the end of the day, and that they're not just another medical record number and just another person that they saw that day. So all of this included lots of community outreach to partner with shelters. We hosted health fairs at other shelters to get the word out about the clinic. We also hosted health fairs at domestic violence shelters. And then we also incorporated better hiring practices of staff to ensure that the staff was diverse in both lived experience and identity, to increase representation of LGBTQ and BIPOC staff specifically. And then all of this honestly did play a role in suicide prevention, because we had the overarching goal of increasing connectedness to the care team and the medical establishment. And that connectedness, as we know, is a really important upstream factor in suicide prevention. Okay, so I also did some other work at a different clinic at Bellevue, and this clinic specifically was built for patients that were survivors of torture. And so basically right here, what we did was that most of the patients and clients that visited here were refugees and immigrants. And so because of the nature of the trauma that was experienced by clients, and we use clients instead of patients in this clinic specifically. So we knew that it was important to screen for psychological triggers, because PTSD and other forms of psychological conditions were unfortunately very common here. Even more so, we learned a lot of clients experienced violent harm perpetrated by the medical staff in other countries that they fled from. And so we learned in these psychological trigger or screenings that the triggers were white coats, for example. And so a lot of the staff, we didn't wear white coats. And because white coats ubiquitously are incredibly symbolic of the medical establishment, even in different countries. And so people also couldn't stand by doors. We all typically stood in the patient's or in the client's view, because we did not want to block that, as it typically was a trigger for clients here, unfortunately. And we ultimately just wanted to create an environment that was incredibly supportive and not triggering for clients. So here's where we also utilize cultural brokers. And so what cultural brokers are is that they bridge the linguistic and cultural divides between patient and or client and provider care team. They serve as a liaison, a cultural guide, and a mediator. And they helped patients understand Western medicine and helped providers understand Eastern medicine. And so basically the way that I like to kind of view this is that, for example, sometimes being a multilingual person myself, some phrases in different languages don't translate very well over into English, or they just don't make a lot of sense into English. And so what cultural brokers were able to do is that they provided that cultural context that really helped providers understand what was being said. That way, a translator, for example, in this instance, just provided the rote translation, but a cultural broker was able to provide that important cultural context. Similar to how in the US, like different regions have their own phrases that may not resonate in other regions of the US, or different like slang, I think. So that's kind of how I like to see it. And that's how it really worked for us in the clinic. So all of these strategies of incorporating psychological trigger screenings, incorporating cultural brokers as part of the care team. We also incorporate the same shared decision-making emphasis and patient-centered model from the safety net clinic that I mentioned. All of these work together to increase connectedness, as I mentioned, being an important role in suicide prevention. Okay. So I know that was really speedy and a whirlwind of information. So I figured I would pause right now and just hold some time for a question and answer for folks that have any questions.
Thank you so much, Magna. I actually have a question. And kind of like building this into what care looks like at Bellevue, were there any obstacles, either internal, external, people saying, I don't know how to do this part of it, or like this part feels tougher? Like, were there any barriers like that you could speak on while you were implementing this amazing trauma-informed care lens?
Yeah, I think that the biggest barrier that we experienced was that, for example, with the psychological triggers that a lot of clients were dealing with. For example, when we were trying to say if a client had to be referred outside of the clinic to another specialty, we were able to actually document those psychological triggers in the electronic medical record so that the other care team, for example, knew just how to approach the situation. And we also had the cultural brokers as well as some other health navigators go with the client to these other appointments. But that was all a lot of thinking through that we faced. I mean, it took months. And honestly, right as I left, we were just kind of getting into the flow of things. And that was like 3 years. So it definitely took a lot of thinking through, and especially because white coats, for example, are so embedded in the hospital system, it can be hard for people to just take it off. And they also are a protective mechanism for people that are doing more invasive procedures. And so instead, like, for example, if they had to get their blood drawn, we just had providers kind of compromise and use like a surgical gown instead. And that was far enough from the white coat trigger for clients that it worked. And so we just really had to like do a lot of communication with other providers in the hospital and to get them on the same page too, all way before we referred out if needed. So, but we tried to keep as diverse of a care team as possible with psychiatrists, for example, psychologists, primary care providers in the same clinic so we could minimize the referring out too. So I hope that answers your question. That was really long-winded.
No, it absolutely did. Thank you so much. I saw a couple people come off mute. You might have more questions.
I have a question as well, if you don't mind. I was approached last week at a conference and twice by the executive director of the African Chamber of Commerce, and her name is Maya Wheeler. She expressed that they didn't have any individuals down there that's providing trauma courses or anything or mental health information for the African population, and asked if I could connect them to mental health treatment and connect. And I, of course, went to my supervisor already. But what would be the process? Like if an organization do not have the those resources, what would be the first process to connect the African population, refugees, and those that are suffering from exactly what we're talking about, the trauma? What would be the first steps to get that process going?
Yeah, that's a really good question. Thank you for asking. So what we found, what was helpful was that we referred out to specific organizations that did service, for example, a lot of refugee and immigrant communities. So for example, in Colorado, I do know for the Asian community, there's the Asian Pacific Development Center, and they do work specifically with refugees from the Vietnam War that settled in Colorado. So that's what I would do is that like there are some organizations and specifically in Colorado that do, to my understanding, even the International Rescue Committee, I believe, also does work with refugees, specifically in refugee settlement in Colorado. And there are some services offered by Colorado Department of Human Services. So I can try and like compile a list and like follow up with you via email too, if that would be helpful.
Yes.
Yeah, I would love to help and
Yeah.
connect on one more.
Yeah, try to get them into those individuals, and the way she expressed it, that they're really in need of it and just didn't know how to or who to reach out to. I just happened to work at Wellpower at the time, and I was like, well, let's see if we can get. So yes, please, let's do that. Let's get these individuals that are suffering and don't speak the same language we speak, the cultural brokers that they need in order to understand the information, if we can. Thank you so much, Megan.
Yeah, thank you for your question.
Yes, I appreciate you.
Thank you so much. This is amazing. I don't know if you saw, there's one more question in the chat that I think we have time for down at the bottom there.
Yes.
Yeah, how do you determine which patients could benefit from a cultural navigator?
Yeah, okay, so what we did is that basically we assigned cultural navigators or cultural brokers to basically every immigrant and refugee patient or client that we particularly serviced. We just found that it was a need because, first of all, there were very like inherent language barriers. And also they were coming from other countries that don't practice Western medicine, for example. And Western medicine, as we all know, is so different from what is practiced in other countries. I mean, for example, physicians have to do their own residency here if they come from a different country. And so with all of those different barriers and just wanting to make clients feel very more attached to the care team and more connected to the care team, as opposed to just, well, they don't understand what I want, we don't understand what they want. They really were able to be that mediator. And it became pretty apparent, like from the get-go, from just like initial visits with clients. And so I would start ubiquitously with any immigrant and refugee person that you do provide services for that do have those language barriers. So I would start there and then kind of like assess as needed. And that's basically what we did. So I hope that answers your question too. And I can also follow up by email, which the next slide has my email on it. So feel free to reach out to me. I check it 24/7, it feels like. So I would love to connect one-on-one with you all. And thank you for the great questions. It was such a pleasure to present to you all today.
Thank you so much, Meghna. This was amazing. I think super useful, and just like the way that you went about your approach with this, it's trauma informed, it's culturally responsive. You put it into the EHR so you can communicate with other providers and really look at it with that quality improvement lens that the Zero Suicide Framework is all about. So thank you so much for sharing. Again, Meghna's slides and contact information will be distributed after the meeting. So please do get in touch with Meghna. She's a pleasure to work with. And I'm also super excited to switch gears in some ways and talk about regional health connectors and the amazing things that they are up to. So I will go ahead and toss it over to, I think Julian and Hannah are getting started, but I'll let you share your screen and go from there. Thanks so much for being here.
Thank you so much, Conlon. And yeah, Meghna, amazing resources. We'll probably be emailing you to come talk to the rest of the RHCs at some point as well. So my name's Hannah Groves. I use she, her pronouns. And with me today is Jillian Grant and Jamie Fanslow and Susan Garrett, and I'll let them introduce themselves.
Hi everyone, Jillian, she, her pronouns as well, and I'm one of the program managers for the Regional Health Connector program.
Hello, my name is Jamie Fanslow, she, her pronouns, and I am the Regional Health Connector for Gilpin, Clear Creek, and Park counties. I stepped into this role back in January.
Good morning, everybody. I'm Susan Garrett. I'm the Regional Health Connector for El Paso and Teller counties.
And I didn't say this, but I am also program manager with Jillian. So this is a 101 presentation that we've done a couple times and we thought it'd be appropriate for this audience. So we're gonna just go over who we are, what we do, what our program looks like, and then how to connect and support, and really focusing on that reciprocal nature that we love of supporting you all and having you support us. And then opening it up to Susan and Jamie, because really they're the ones with the boots on the ground. They're two of our fabulous RHCs, and we're happy that they're here to share what they're doing and what they hope for the program. So opening it up, if you're familiar with the RHC program, what do you know about us? If you're not, that's okay. And what are you hoping to learn today? If you want to type it in the chat, that'd be great. Oh yeah, we love Mary. Yeah, definitely doing some behavioral health work. Okay, good. So kind of a mix maybe of people who know an RHC and love them and people who are ready to love them, right? So a little bit about the Regional Health Connector program. So first, to just touch on the partnerships that Head Institute is where Jillian and I work, and we are the program office. So we provide technical support and coaching, but not supervision. And then we also work on some evaluation and sustainability of the program. And then we also partner with CU University of Colorado Anschutz, the medical campus, and specifically the Department of Family Medicine. So they serve as our fiscal agent. They help a lot with evaluation. Thank gosh, we have those data brains over at the university. And then they also help with sustainability and advocacy at the state level. And then Colorado Health Institute is also a really valued partner that has helped us sustain the program over the years. And right now they're serving more in that like future visioning and sustainability, as well as some advocacy for us. The vision of the RHC program is that connected systems will lead to healthier lives for all Coloradans. So that systems level piece is something that's really important and is kind of what differentiates RHCs from like a health navigator, a community health worker, or people who work one-on-one with families and individuals. We are right now, we're going to work on a graphic to kind of help better communicate, because systems level work is really hard and it can be very informal and difficult to talk about, but that's what they're doing every day. And so hopefully this presentation helps shed light on what that looks like. Because ultimately the mission of the program and of the RHCs is to improve health in Colorado by connecting the systems that keep us healthy. And that includes primary care, public health, social services, and other community resources. And that other bucket is really big. That can be justice systems, that can be school districts, that can be a lot of, and faith communities, that can be a lot of people that are not always at the table when we talk about health. So the purpose of the RHC program, we have the goals listed here, which are those red bolded or statements. And then really what I want to draw attention to is the how, the strategies of how RHCs do their work. And then we've started this connecting piece, and connecting clinics to community assets is really where we hear and see the RHCs having the most impact, because they are locally embedded in their communities and they really have their eyes and ears and hearts in their community and know what's going on, know where the priorities are, know where the gaps are, and really bring that to the table. And I think that's where a huge piece of the value of RHCs are. But they do all these other things too, and we really appreciate that about them. So as far as what the program looks like and how we operate, once again, RHCs work across systems. So these little blue people with their hands in the air like they just don't care are really those people that are working in the Innovation Support Project, which is a program through the university, and that's really working on those clinical community linkages. So these practice facilitators and CHITAs, community health or clinical health information technology advisors, which is a mouthful. I always stumble over it. So you can see the PFs and CHITAs are embedded in the clinic, but the RHC is outside and connected to these other systems, and really sometimes the nexus of making sure that all these groups work together and are talking and coordinating. But they really do have a direct connection with a lot of clinics through that ISP work. So we find that that's really valuable, but then they're also outreaching to other groups as well. And I'm handing it over to Jillian here.
Hey everyone. So currently we have 19 regional health connectors who live and work and play in the 21 regions across Colorado. And these overlap with the health statistic regions out of the public health department. The regional health connectors are embedded in their communities, and they're employed by a local organization on purpose to really keep the work local based on community priorities of what is identified. Some examples that we have of host organizations now are local public health agencies, area health education centers, which are affiliated with the CU Anschutz campus, but they're based locally and located locally in communities and help provide education for nursing and doctors. We also have folks who are housed in health alliances, as well as nonprofits or community-based organizations. Next slide. Currently, so what Hannah already mentioned is some of the work that RHCs are already involved in is under a stream called the Innovation Support Program. And with this funding, regional health connectors are fostering that collaboration and connection between clinics and community. And clinics can be anything from a medical practice to a hospital, and linking them with that public health and community services and resources. They also are addressing and highlighting the social needs in the communities that they're in, and what some of the priorities are for their region. We also have just completed this Behavioral Health Recovery Act work. So we were funded through some Senate bill funds to complete an assessment of their region, both the strengths and the gaps, and creating an action plan to kind of address some of that. And Susan and Jamie will share more about their localized work, so you can have an understanding of some examples of how that went and what they did. Next slide. Some other efforts that regional health connectors have been involved in. So with the MAB project, some regional health connectors were involved in supporting the outreach and communication around the monoclonal antibody treatment, and that was from last summer throughout the spring of this year, and helping design communication materials as well as disseminating it in their regions. We also had a smaller project in helping support county jails to address needs of folks who were being released from jail and getting on Medicaid, as well as getting behavioral health support for substance use disorders and co-occurring mental health disorders. And then a smaller localized project during COVID-19 through the Office of Behavioral Health. Regional health connectors supported work around getting resources out for folks who are experiencing homelessness to have COVID-19 resources that included prevention, like vaccines, mask support, testing, as well as getting information out about treatment options if needed. And then we are so lucky to have the owner of this quote here, Miss Susan, and really highlighting just the really key parts of the RHC work. Really responding to what the needs are and the priorities identified in the community, really being localized focused. And that's a key component of that community engagement piece. Next slide. All right. So based on all that, what are ways that you can connect with us as a program as well as individually with regional health connectors? So we have a website, and on there we keep this updated as up to date as possible. There is a Connect with Regional Health Connectors tab, and we have everyone's lovely faces so you know what they look like, as well as their emails and where they're housed in their communities and what organization employs them. And really, these folks love to connect. So there is no wrong email, no wrong question, as our RHC in Denver highlighted. Reach out anytime. These folks would love to chat with any and all of you. Next slide. Ways to partner with us or all the RHCs. We send out weekly emails with resources to the RHCs. If you have a resource to share or you want to be connected, let us know. Conlon has been great at sharing a lot of the great information, and we've definitely shared that out. We also host a set of learning calls every month with the Regional Health Connectors. If you'd like to see all their lovely faces and present about programs that you have or connect on a resource, or connect with the group at large, you're welcome to join us anytime, as well as getting in contact with Hannah and I for larger connections to the program, to what's going on at the state level with this program, and things like that. Next slide. And we would love if you would advocate and amplify the great work that these folks do. Feel free to dig around on the website. There's a lot of great information on there. I think my favorite page is the stories of impact. We have a lot of really great stories about the localized work that RHCs have done. It does not have everyone's story yet, but will soon. And it's a really great way to understand the work in action of the Regional Health Connectors. Feel free to reach out to us and partner with us. We are happy to collaborate. That's how we do things better together, right? And more efficiently. And spread the word. Talk to folks that you know, share about this program. It sounds like some folks are already connected to Regional Health Connectors, so you know the great work that they do, and definitely share about them in spaces, internally, externally, whatever makes sense for you. And I think that's where we turn it over and you can hear about some of the work that Susan and Jamie have done this last year in regards to their behavioral health projects. I don't know who wants to go first, so feel free to, to pop in. Susan.
I'll jump in. So again, I'm Susan Garrett, she, her pronouns. I am the Regional Health Connector for El Paso and Teller County. And I do have to put a little caveat on the contact thing for both Jamie and I. Our emails will be changing after July 1st. And unfortunately, we don't know what the new ones are going to be. So if you want to email me, either do it soon or wait till after July 1st and check on the website or check in with Jillian and Hannah. So I just want to let you know that. I just saw a question in the chat. How does the RHC differ from the Medicaid case managers through the RAISE? Very different. We don't work with individual patients. We work with systems. We collaborate with the Medicaid case managers, sometimes at feeding them resources and finding resources from them, but we don't work with individual patients or families. Sorry. So I just want all of you out there to imagine that a year ago today, you were tasked as one human being to pick one behavioral health priority that was of importance to your community and make an impact. Ready, set, go. And you have a year to do it. I'm looking at Hannah. So that's what we got. And because we're RHCs, we actually thought that was super cool and exciting. So we did a mini assessment of our community and talked to our partners and said, you know, what's bubbling to the surface? And what bubbled to the surface for El Paso and Teller County is access to safe and affirming behavioral health care, specifically for LGBTQ plus youth. Because if you look at websites for behavioral health care provider or other resource lists, they just check a box saying, yes, I care for LGBTQ plus folks. Yes, I care for this. But that doesn't tell you that they're gonna be safe and affirming. Especially in our more rural counties, there still exists folks who negate people's identity, even professionals. It breaks my heart to say this, but there still exist professionals who negate people's identity or try to change people's identity. And it becomes even harder for kids. because, people talk and there's social networks. So if you're older, it's kind of easy, not easy, but it's easier to find somebody. But I actually had several parents reach out to me who had, 8 through 12-year-old kids who were suffering with either anxiety or depression, and were gender not, whatever the word is. Do you know what I'm saying? They were gender expansive. And they wanted to make sure that if they took them for help, that it was not going to be a traumatic experience. So that really quickly became a priority for me. So what have I managed to accomplish in the past year? We've pulled together a network of folks who are coming together to work on this issue from a broad variety of organizations and perspectives. We've established a way to get the youth voice into our network. The young folks don't necessarily want to attend meetings, but we've established a safe way to get input from them that's safe for them, and they don't have to come out, they don't have to be seen at a meeting and and we've developed a plan going forward to increase our capacity around folks who have some training and expertise in working with LGBTQ+ folks, and working on developing an accessible resource list so people in need of care can find somebody. And the super exciting program part is Pikes Peak Community Health Partners got a grant. So this work will not end on June 30th when the RHC portion of the funding ends. And they have hired a full-time employee who's going to take this even further. I started with behavioral health care for LGBTQ+ youth. It is now expanded to all forms of healthcare for all kinds of people. And there's funding to make it go forward, and a dedicated community group to advise and promote and expand this work. So super exciting. And I saw that. It's so great to hear, Conlon, and I just really want you all to share. That funding was just, I had nothing to do with it, and it's the best thing that happened for our community. So I will pass it on to Jamie. Should we hold questions for the end, Hannah and Jillian? ? Okay, so I will pass off to Jamie.
Yes, thank you, Susan. Yes, my name is Jamie Fonslow, and I serve as the Regional Health Connector for Region 17. This covers Gilpin, Clear Creek, and Park counties. And for our behavioral health project, our population of focus was rural adult caregivers, early learning and youth program support staff, and school district staff. And one of the gaps we identified in our region was adults who care for mountain communities need resources that strengthen self-care skills and skills for supporting the needs of our youth and children. So our proposed solution focused on connecting adults who support youth and children to supportive mental health programming. And also we looked at ways to increase effectiveness of the promotion of existing and new behavioral health services. So in Gilpin County, we had the opportunity to work with the Gilpin School District. We brought programming to the school district staff here at the end of the school year, programming that supports self-care, resilience, just healthy strategies for coping as we work to come out of this pandemic. Also in Clear Creek County, we worked with Clear Creek Metropolitan Rec District and their summer camp program staff. And we brought programming, again, similarly, resilience, self-care, healthy coping skills types of programming to these summer camp staff. And these are folks who are high school students, college students, and we brought in, we worked with 3 behavioral health resources providers in our region who provided the programming. And this was programming that they had never, these providers had never worked with these entities. So they were excited to make that connection with this new population. In Park County, we worked with the Boys and Girls Club of the High Rockies and their summer camp staff. So again, high school, college age kids. It was interesting, we brought the QPR training as part of this training. And it was really poignant. The evening before, our participant attendees had all attended a memorial service for a close community member who had died by suicide recently. And so we hadn't anticipated this, but we had planned the QPR training as they head into their summer working with youth and teens and children. And it was a real, I think, timely and poignant opportunity to reach this group. And as far as sustainability, we are hoping that the relationship that we built between our behavioral health providers and these community organizations will continue. They're already talking about come fall, providing another round of behavioral health programming. So thanks so much.
We're dropping all the links in the chat that you could ever need. Thank you so much, Jamie and Susan. We'll open it up for questions now. If you have questions for Jamie, Susan, Jillian, or I.
I have a question, but it's kind of general, and I don't know if there will be a solid answer to it, but you've had this program in place. You've seen some of the amazing impacts. For everyone else on the Learning Collaborative call, please do sign up for their newsletter and peruse their website. There's just a ton of good information and resources and stories on there. But I guess having been doing this work, seeing the impact in local communities around the state, what promise do you see for this kind of systems level approach for the regional health connectors? Do you think that this is a sustainable approach? If health systems are reaching out to you, what impacts do you think you could help realize together? So I know that's like a large question, but just curious your thoughts after having heard from you guys today.
I'll start, but then I want to hear from the rest of my team. Okay, so full disclosure, I have a bias because I love this program. But the hard part about the sustainability is making the case for why these like systems level folks should be in place and be paid and paid well to do the coordination and collaboration and facilitation and convening and connecting and all those things that they do. I think a lot of people think that this is happening naturally, or they're like, oh, well, we have this position that's also doing this on the side. But really, I think it's going to take just recognizing that this like systems level piece that's kind of messy and hard to capture and talk about is still so important to fund, and to fund right now, and to fund long term, because as we're learning, it really takes all of us. It takes a team. It takes people who have never been at the same table before, and especially the people who have continually been excluded, right, from those tables. And I think that's what the RHCs can help facilitate and bring. But it is hard to fund. So if y'all know grants, if you have projects, let us know. But yeah, I'm really interested to hear what Jillian or the RHCs think on that too.
Yeah, you said it great. I think the one thing to add is like, we know that systems level change work takes so much time to really report out on like some of the impact and outcomes. And we've been really fortunate with being able to see the impact with this behavioral health work actually, and being able to report out on that. And so But again, everything ties to funding. That's the world that we operate in this nonprofit model and public health model. And so we're also, our hands are kind of tied in that way. However, I feel pretty hopeful. There's a lot of folks at the state who have recognized the benefit of the regional health connectors, similar to what some folks have shared here in the chat. And we were witness to that in a recent House bill testimony in this last legislative session. So we're feeling pretty hopeful for the next legislative session. So in getting funding support, that is. So I have hope. My gut feels good about it, but we'll just see what happens over this next year. That's a really good question, Colin. Thank you.
Yeah, and I have an add-on to that. First of all, I mean, total kudos to Jillian and Hannah for advocating for this program and advocating for keeping funding going. And one of the challenges they have is when you're looking at grant funders, that grant funders tend to be a top-down approach, or they want everybody in the state to be doing the same thing. And the beauty of the Regional Health Connector program is that's not how it works, because the flavor of a program looks very different in El Paso County than Park County, than Arapahoe County, and it needs to in order to be effective. But that's a tough sell with funders.
Yes, and I'll just add to that. Systems change work happens in very small steps, small baby steps over a long period of time. And so we don't have the big bang to report on. And that also is a hard sell when we're looking at long-term efforts, real small increments of baby steps to reach our goals. That's a little bit of our challenge, but we're sticking with it and we feel hopeful.
Awesome. Thank you so much. That definitely answered my question. I just have a really deeper appreciation of the systems level work that you're all doing. You're right. This is the work that you look at and it's a huge problem. And you're doing that work, that connections between systems in our state. And I just want to say thank you so much for sharing that today. I will definitely include contact information and slides in a follow-up email if that's all right with you all, just in case. Please connect with this crew, connect with your regional health connector. Really excited about the work that you're doing. And thank you so much again for sharing it today. We only have a couple minutes left. If you haven't already, please drop your name and your organization into the chat. Again, related to what we just heard from the RHCs, when you get these slides, please do feel free to click through these free training and orientation materials relevant to supporting LGBTQIA+ individuals in your community and otherwise. Some funding opportunities there. And I'm also going to include a different collection of funding opportunities that we just got sent as well. But thank you everyone for being here today. Really appreciate your time as always. Again, our next meeting is going to be on Wednesday, July 27th at 10 a.m. versus our typical fourth Thursday of the month. I am happy to give you only 2 minutes back in your day today, but we had so much great information that I'm not too upset about it. I will be hanging out in the Zoom room for office hours from 11 to 12. I'm going to take a brief break to stop the recording and my video for a second, but then I'll be back in if anybody has anything that they'd like to chat about, opportunity to collaborate, troubleshoot with zero suicide. But thank you so much again, Meghna and the Regional Health Connectors, for your amazing information today. And I hope you have a great rest of your week and weekend. Thank you, everyone.